So if I'm a patient walking into your office and I've decided that brachytherapy is for me, especially with HDR, what is the setup? Like, what is the type of conversation you would have that you would like me to be aware of before I would have the procedure?
Well, we spend a long time talking to patients about the nature of the treatment, the nature of their illness, the various treatment alternatives that are available to them. Particularly in prostate, you have to go down the long list of internal and external radiation and surgery and androgen suppression and so on and so forth. So those kinds of consultations are actually quite long and detailed. And once I feel the patient, I've developed some rapport with the patient, feel like they understand, then we go on to, after having reviewed their particular case data set, make a decision with them about what makes sense. And some people want to think about it. Other people are ready to go, and it's pretty straightforward, HDR monotherapy, or you have to be, use external beam and coordinate the care and hormones and so forth. So it takes a little bit of time to go through the process. And once you've made the decision, let's say you have intermediate risk group prostate cancer and you've chosen HDR monotherapy, we make sure that you're medically fit to undergo the anesthesia, which is spinal. It's not particularly stressful. It's not brain surgery. It's not heart surgery, open heart surgery, anything like that. It's transcutaneous and not very stressful. So patients from all walks of life and degrees of health are potentially candidates for this outpatient procedure, and we explain what you need to do in advance, the preoperative measures, which are relatively minimal, and then arrange for the patients, once there's insurance authorization, to come in on 2 separate days, a week apart, and we do the implants, and then we follow the patients after that. The patients do have a catheter inserted at the time under anesthesia, and that catheter is removed. That's true for any treatment of prostate cancer, but that catheter is removed prior to the patients going home in 98% of the cases, 98% of the cases. So they go home and they have frequent urination and, irritative things for about 2 weeks. And then lo and behold, they get a whole lot better. Within a month, I would say 90 to 95% of the patients are close to back to their sort of baseline urinary status. And there are some patients who do have more prolonged irritation, but if you wait it out, almost all of those get better without any intervention as well. So it has a relatively well-tolerated, low long-term risk profile, and patients are pretty happy about it. And that's not to say that you have to select your patients properly. There are certain patients who maybe have very large prostates, who have problems that may need to have some kind of surgery beforehand. They could potentially have a radical prostatectomy as an alternative, or they could have a transurethral partial removal of the prostate to open up the channel. There are some circumstances where it might be better to take another approach, but I would say of people who come to me for a consultation, more than 90% of them are good candidates for proceeding with the procedure.
So if you would like more information about anything we talked about, you can go ahead and contact our helpline team and they will be available to talk to you. The number is at our website, pcri.org, and you can look up other information on prostate cancer treatments. And if you like this video, go ahead and give us a thumbs up. The reason those thumbs up matter is because that lets Google know that this video is helpful to you and it can help other patients, and we get on a suggested video list. Subscribe to our YouTube channel if you would like more information in general about prostate cancer. We cover every topic we could possibly think of, and we hope you have a great week.